Good afternoon, everyone. Today is August 26, 2021, and we are back to another COVID-19 live stream. Today is August 26, 2021, and we are... Just got rid of the echo. All right, so we're going to start today with Dr. Jameson going over a COVID update, then we'll get into a few speakers.
Okay, thanks, Jasmine, and thanks everybody for joining us. There is a live chat for this stream, so please feel free to put your questions in there. We will be recording this so that others that aren't able to join us right now can join when they're able. So it's been a while since we've done one of these, but I think we're at a point now where there's a few bits and pieces that are worth talking through and sharing and updating people on. So we will dive right in. As you all know, we've had quite a surge or peak or whatever you want to call it in cases over the last few weeks. We are cautiously optimistic that we may be beginning to see a plateau in new cases, and just understand that a plateau in cases would be followed at some point later by a plateau in hospitalizations, and then followed even later than that by a plateau in deaths. So we do expect hospitalizations and deaths to lag behind case counts. So first we see the cases plateau and start to go down, then we see the hospitals, and then finally the deaths follow that. So that's kind of where we're at. Everybody's been working incredibly hard. But there are some pieces of news that are worth talking through and answering any questions on, so that's what we're going to try to do today. The couple of topics that we're going to try and cover is the full approval of the vaccine, at least the Pfizer vaccine, that happened on Monday. And then we're also going to try to review, talk about, answer questions about, and hopefully help with understanding of the antibody treatments that are available out there. And then one or two other treatments we'll also mention that folks are, or supposed treatments anyway, that folks are maybe hearing about in social media or the news. So that's kind of our plan for today. We're going to try to keep it to 1 hour or less, but we will stick around and answer as many questions as we can. So feel free to go ahead and start putting questions in the comments. Billy, you're already getting shots fired at you, so sorry, buddy. All right, so with that, I'm going to turn it over to Craig Hare, who wanted to join and say a couple words today.
Sure. Good afternoon, everybody. Craig here. I'm the Director of EMS and Fire Administration for the county, in case you're new and didn't get to see me on last year. I don't think any of us thought that we're going to be a year and a half into this and still have this situation. So we understand, we really appreciate all of the personal sacrifice, the family sacrifices, the just sheer hard work of people being on mandatory overtime and callbacks and everything else. We just really appreciate everything that everybody's doing. The 911 operators have gone just above and beyond and handling the communications changes, whether we're doing pandemic EMD or not, or just everything in between. Fire rescue, we really just wholly appreciate all of the Condition 3 medical, the rescue units stepping up to handle the transport mission to assist Sunstar. Sunstar crews have just gone above and beyond. This really impacts everybody. ALS engines are out more while the rescues are transporting. So it's really just impacted everybody. Dr. Jameson and all the EMS physicians have gone above and beyond. They're up all night on online med control and handling system status management of the hospitals. Just everybody around the board. Central Supply putting together PPE and keeping those shipments going out to you. And so directly to the field, the professionalism and the level of care has just been stellar. And so we have not heard word one from a hospital or a citizen. Matter of fact, our QARs are down, our complaints are down, and the level of accolades and appreciation that we're getting is by and far much higher than any type of citizen complaint or hospital complaint. So that professionalism and high level of patient care just has been cornerstone. You all have been incredible advocates for our patients, especially in getting care at the hospitals. Our partners really have been very supportive and very appreciative of us. Department of Health, the county administration, the city administrations, just everybody across the board, the EMS Advisory Council, the Medical Control Board. We've been working daily with the hospitals administrators, and we've got a very close working relationship with them. They're returned to about 80% of our patients being placed normally at the 15-minute mark, and our greater than an hour has been under 20, which in this given time is very good. As long as we can continue to do that and keep ourselves off of running out of rescues and ambulances, frankly, we will try hard not to use the 2 medical plan, because it will have an impact on patients and it will have an impact on the hospitals. So to the extent that we can help them out, we are going to work with the hospital administrators to try to do a 2M plan that could be just for a single hospital or a region. That's not out yet, but we're working on that. We are seeing about 10 or so patients from nursing home to hospital, and we're seeing a lot of hospital discharge post-COVID. So there's a lot of efforts here, and we really appreciate everybody's hard work. We're going to continue to work on the EMS hospital plan. We're watching that every day. The new peak transport units are out, and they do give us a little bit of relief. That little bump in the afternoons really has been helping. And so I did want to just mention that we try to stay on condition 1 for as long as we possibly can. That doesn't mean that you can't do fire rescue transports. You just follow the normal plan. Level 1, if it's a condition red patient, as load and go, or an online consult. The doctors and Sunstar Dispatch are doing this every day. So those are quick consults. They're deciding, we just don't want to send 2 transport units to a single patient when we're in normal operating. Or when, we need to have a fire rescue transport. There's no need to tie up both. Overall, when we go to 3M, it's a big change for the system because we suddenly have 36 rescues all transporting. That's a huge impact for Sunstar to redeploy, and it's a huge impact on how the first responder program is working. So it's working well, it's very smooth, but we don't like to turn it on at the first instance that we have, just a single call held or sporadically a call held. We want to wait until we see a need that we've got a growing queue of non-emergencies, or we've got a big spike in emergencies. So the administrator on duty for Sunstar and I look at that in real time, and then you'll see, pretty closely that just a few minutes after there's a big spike and you see calls unassigned with Sunstar units holding, that you will see us enact that. But we've tried to turn that down over the weekends. Last 2 weekends, we've been able to go without it. And we've been shortening up the times. Last night, I think, was about 3 hours. It doesn't mean that we won't use it if we need it. We're just trying to stabilize the workloads on the rescue units and try to have Sunstar be the primary transporter, to follow their contract and the system design. Sorry if I took a few minutes there, but I'll stay on for any questions. Thank you, Doc.
Okay, thanks, Craig. Appreciate the update there. I know people did have some questions about that kind of stuff. The one thing that I thought might be worth mentioning is and maybe I missed you saying this, but the fact that 2M and 3M are very much independent kind of things.
Oh, yeah. Yeah, Doc, that's a good reminder. So unfortunately, when I wrote it, I thought that they would be sequential. but the first time that we went to use it, we actually were fine in terms of fire rescue transport units and ambulance units being available, but the hospitals were the problem. And then the next time it was exactly the opposite. So, unlike the other condition codes that go in sequence, these can really be done individually. I did talk with Unified Command about this, and it seemed like there'd be more confusion if we renamed it again. So just a reminder, and we will put it out in the next guidance coming out, that a 2M is individual, separate from a 3M. 3M we're using more regularly. 2M is only when we have to clear units from hospitals rapidly.
So you could be on both 2M and 3M at the same time, or just one of those and they're just completely independent.
They are completely independent. And something also that I never contemplated is last week we had a number of fires and lightning strikes during some heavy storms. We actually went from condition 1 to condition 2 to condition 3 on the fire side, and simultaneously we're condition 3M for transport. The operations chiefs are looking at automatically going to condition 2 when we're on 3M. So you may see some additional changes coming from that. But we can do those, as you say, Doc, all independently depending on the scenario.
Great, thanks. All right, enough of that operations kind of stuff. So put any questions for Craig in the chat, and we'll try to get him to answer them before he has to move on to his next thing. But with that, I think we want to turn over a little bit to discussion point number 1, which is the vaccine and its approval status. So just so everybody is aware, in case you missed it, as of a few days ago on Monday, the Pfizer vaccine was given full FDA clearance for those, and correct me if I misstate anything here, Dr. Cho, but for those age 16 and above. There's still EUA allowed for down to age 12, but they've given its full approval for age 16 and up. So that's a real kind of important milestone for us in this fight. Just as the initial EUAs were a big milestone and we could kind of start to take the fight back towards the virus instead of just being on the defense, I see this as a very big milestone as well. And it doesn't change anything in my mind about the vaccine. I was already very confident in the data surrounding the vaccine and its safety profile, but I think it does sort of give a stamp of approval to it, which may be helpful for some who are still on the fence. Again, I've never seen a vaccine at any point in my career be scrutinized this carefully, have this much data collected about it, be given to so many people over a period of 8 or 9 months, and really not have any significant safety issues be identified. And I'm convinced that the mRNA vaccine technology is a better technology than any previous vaccine technology we ever had, whether that's your hepatitis vaccine or your measles and mumps vaccine or your meningitis vaccine or any of the other vaccines that we give to people, as kids or before they go to college or when they're in high school. So I'm very, very happy with the performance of the vaccines from a safety standpoint. And I think that this full approval really just reinforces that. I do know that there is a fair number of people who were saying that one of the reasons they were hesitant to get the vaccine was because it wasn't fully FDA approved. And I hope those folks will take this opportunity to reconsider and to consider getting the vaccine as soon as possible. I think it's clear at this point that the vaccine is our best tool in this fight. So that's sort of my take on the FDA news of this week. Dr. Cho, do you have any other take on that?
No, I think you hit all the points. The county did recently send out a survey on vaccine hesitancy. I think they surveyed something in the ballpark of 2,000 residents. And one of the biggest barriers and concerns for residents that sort of on the fence on the issue was that FDA approval. I think there was a misconception, it's sort of erroneous there, that the emergency use authorization falls into the experimental category when that's not the case. The difference between an EUA and FDA, because we've touched on this before, full FDA approval, is that it's more of administrative. The same clinical studies were conducted with the same number of sample sizes, 30,000 to 40,000. The same safety profiles, the efficacy data is just there. It's so there isn't a huge difference other than following more the bureaucratic process of the FDA difference between the EUA with these vaccines and the full FDA approval. The good news I also heard is that the Moderna, the other mRNA vaccine, just applied for a full approval as well. So we're looking forward to that.
Yeah, I would agree. I don't think the EUA really is, or the change from EUA to full approval indicates any particular change in the science or the data, but maybe just another look at everything and making sure we haven't seen, any other signal. And you're right. It's EUA is not the same thing as experimental. And in fact, if you look at the size of the studies, the initial studies done on these vaccines, and you compare that with the size of the studies done on many other vaccines that have been commonly in use for many, many years, these studies are by and large larger than studies that were initially done on lots of vaccines that we all had as kids or give to our kids. So I don't think that there's any big thing there. Again, it's hundreds of millions of people have received these vaccines over the last months, and there's really no signal whatsoever of any real problem with them. Speaking particularly about the mRNA vaccines, the Pfizer and the Moderna. So I do hope that people that had still not chosen to get the vaccine will take this as a moment to reconsider and hopefully get the vaccine. I hope that that those who were saying that this was part of the reason for their hesitancy will not simply pivot to another reason why they don't want to get the vaccine. I hope that was a true statement, and I hope that we really do see a significant increase in the number of folks who get the vaccine. And I'm not just specifically talking about first responders or EMS folks. I'm talking about our country as a whole. So there's one or two questions in the chat, and I'll just address them real quick before we move on to the next topic. And one person says, are we looking at mandating the vaccine in the county for clinicians, or is that not something we are doing? That's not something that the county is discussing at this point. I cannot speak for any of the individual cities or districts that make up the system, but that's not something that we at the county level are discussing in any way. It's probably worth noting that some position statements came out from IAFC and IAFF this week regarding those topics, and I would suggest that you might want to go take a look at those position statements if you haven't seen them already, because your professional organizations have opinions on that as well. So that's the first question. The second one is, what are your thoughts on continued protection for those of us vaccinated way back in December and the need for a booster? Great question. I think the thinking on this has evolved. I asked a CDC rep about a month and a half ago if we were seeing this signal yet, and they indicated they did not have strong data on that at that point. I think since then we've seen new data come out from several places, particularly Israel, but several other places that do indicate that at some point, particularly 6-8 months plus after your vaccination, your percent of protection may wane a little bit, and so that's why there's this discussion of boosters. Currently, boosters are only authorized in the U.S. for those who are immunocompromised. So, in the hospital right now, we see most or so for example, at my hospital, as of a couple of days ago, there was 258 people hospitalized. Only 25 of them were vaccinated. There was 111 in the ICU and only 7 were vaccinated. And there was 47 on a vent and only 4 of those were vaccinated. And the majority of those that are vaccinated that are in the hospital are folks who are immunocompromised in some way, meaning that their immune system doesn't mount a normal response to the vaccine. So therefore you don't get as much protection. Most of them, or a big number of them, are organ transplant patients who are immunocompromised all the time. Some of them are immunocompromised for other reasons. So that's the only group right now that a booster is authorized for. But I think it's pretty clear that we're going to see in the pretty near future, I probably within the next month is my guess, but that is a guess. I do think that we'll probably see a booster authorized for those who are over 65 and probably for healthcare workers as well. So I suspect that we will have the option for a booster before too long, though that's still my guess at this standpoint. That has not been officially released. So Dr. Cho, any comments on the immunity sort of waning after a period of time?
Yeah, but if you don't mind, I'll start off with some of my recent experiences. I had the opportunity to visit or stop by 3 hospitals over the last 5 days. I've worked one, I visited 2 others, and it was the same themes, things that you guys are seeing in the field, just massive numbers of COVID patients. I was surprised by the number of COVID units that were converted to COVID units. The seeing how far the staff was stretched, as well as resources. I did hear earlier in this week that there wasn't an ECMO machine south of Pennsylvania. And that's a cardiopulmonary bypass machine for severely damaged lungs and heart. So it was concerning to me because pre-COVID, we use these ECMO machines for severe heart and lung diseases. And during my treatments and rounds in the hospitals, we treated a lot of severe COVID. And really the mainstay and the only drug that's shown to decrease mortality in the severe COVID was steroids. And if their body were not responding to steroids, they really had a poor prognosis. So what I got from these tours and my rounding is that really prevention is key, going back to the importance of vaccines. And I know the numbers are all over the place depending on the study, but what it's showing essentially is that the vaccine prevents by 5 to 8-fold decrease in hospitalizations or death. 25 to 28-fold decrease in death, 5 to 8-fold in decrease in infections. So it really goes to the importance of that prevention. Regarding some of the boosters, as Dr. Jameson mentioned, that they are seeing some potential waning of those antibodies, possibly around the 8-month marker. That even though that they provide still good protection against severe outcomes, hospitalizations, and death, they are starting to wane, especially more on the prevention of infection overall. So I think you may have read in the reports are considering sometime in the end of September 20th is what I've seen of recommending a booster. And that's common with a lot of vaccines after, if you think about it. We had a booster, for example, the pertussis vaccine, the Tdap. So it's not uncommon to do that. And as Dr. Jameson mentioned, really the only, and I'm calling more of an additional dose, is currently what's recommended is an additional dose for the severely immunocompromised. Those are people with organ transplants, those on chemotherapies that had a bone marrow transplant in the last 2 years, AIDS, and certain medications. That should get that additional dose. And think of that additional dose for this particular population as completing their first series. This population don't have that propensity to generate and produce that immune response. So it's just giving them that extra adage of the vaccine to help them generate those antibodies. So let me stop there.
Awesome. Thanks, Dr. Cho. So the next question is from Trevor, and he asks about the case reports of myocarditis in young adults with the vaccine. And this is a question I've had a bunch of times, and something that I've heard from a number of people, including, we actually had one person in the system who asked me directly, who's had some heart issues in the past and was worried about this and couldn't get a straight answer from their own doctor necessarily. And so I did a little digging on this so that I could try to at least, halfway intelligently answer the question. And I did what I usually do, which is go ask people way smarter than me. So the bottom line on this is that there is a potential risk there. It is, again, been a more pronounced signal in young men. And the vast majority of them have had complete resolution of all of their symptoms and no long-term consequences from it. And we're talking about a small number. But I think Dr. Matu, some of you guys may know of or have heard of Dr. Amal Matu. He's one of those ER guys who's also a cardiology kind of guru. And he's my go-to cardiology person for any sort of emergency medicine cardiology question. Some of you have probably seen his like YouTube channels and all that kind of stuff. He's pretty fantastic. And I asked him straight up, I gave him the scenario. I said, this person's worried about the myocarditis. What do you think? He's reviewed the literature extensively on that and is really sort of, like I said, my cardiology guru. And he said it like this. He goes, the baseline incidence of myocarditis in the population is 1 in 20 million. The incidence of myocarditis among vaccinated people is 1 in 40 million. So there's really no significant issue there. It is an extremely rare occurrence, and not something that I think in any way tips the risk-benefit scale for getting the vaccine for really anybody. And in fact, there's really nothing there that I think that anybody in our system here should be particularly worried about for themselves. Next question is misunderstandings regarding the vaccine, prevention of infection versus hospitalizations and severe illness. So yeah, let me try to lay this out as plainly as possible. No vaccine is ever 100%. Against the initial strains that these things were tested, it was about 90 to 95% effective in preventing symptomatic disease. So with the Delta variant, we're a little bit less effective at preventing symptomatic disease, but still very, very effective at preventing hospitalization and preventing severe illness. So I'll go back to what I'm seeing in my hospital right now. There's 47 people vented and only 4 of them have had the vaccine. So your risk of being vented from COVID is exponentially higher if you have not been vaccinated. Just like your risk of being in the ICU, there's 110-ish in the ICU and only 7 of them are vaccinated. So your risk of being going into the ICU from COVID is extremely reduced by getting the vaccine. Now, it's not as good at preventing hospitalization. So out of 250 or 60, 25 or so vaccinated people are in the hospital. So, it's not 100%, and no vaccine ever was, but it is absolutely, without a doubt, effective and in your benefit to prevent symptomatic infection, severe infection requiring hospitalization, requiring admission to the ICU, or requiring being put on the vent. So there is no doubt whatsoever, even with Delta, the vaccine is in your benefit to prevent you from getting severely ill from COVID. So I know there's a lot of discussion about breakthrough cases and these other types of things, but there is no doubt whatsoever that your risk of having a severe case of COVID is much, much higher if you have not been vaccinated. So hopefully that answers Ryan's question. Ryan, I'm going to come back to your other piece later because I have that as a separate topic. So let's finish with the vaccines first, if that's all right. Chief Tedesco, unvaccinated folks who have acquired COVID, is getting a vaccine suggested or not? I'm not sure I totally understand the question, but the clear answer is that a vaccine will protect you. Nothing is ever 100%, but it is your best option for preventing getting severe infection requiring intubation, vented, admitted to the hospital, symptomatic, everything. It lowers your risk across the board.
I believe part of that question might have been asking if you've had COVID about getting vaccinated.
Oh, I see. That makes more sense. Thank you. So yes, the vaccine is 100% still recommended if you've had natural COVID infection before. I cannot tell you how many people I have taken care of in the ER who had COVID months ago and have it again now. And so the single best position you can be in from a protection standpoint, actually, if you look at the studies, is probably recovered from natural infection plus got a vaccine is probably the best position you could be in for protection. So getting the vaccine is absolutely, yeah, thanks, Jasmine. Getting the vaccine is absolutely still recommended, even if you've recovered from natural infection. So there's another statement about modifying my genetics. The mRNA vaccines do not go into the nucleus of the cell. They cannot physically, biologically, chemically, or in any other way alter your genetics. It is just impossible. It doesn't work. That's not the way these molecules are capable of working. Now, it's worth pointing out that older types of vaccines that probably all of us have had do infect you and do go into the nucleus, but these ones do not. They are a newer, better technology. And so that's just simply not true. And we'll get to the piece of that question on monoclonals here in a little bit. But no, monoclonal antibodies do not affect your genetics either. Okay, so hopefully we've covered most of the vaccine questions. If you have any more vaccine questions, go ahead and throw them up there and we will come back to it. But now I'd like to pivot over to some other therapies that are out there. So we all heard a lot about hydroxychloroquine. And hydroxychloroquine is a drug that we use for certain things, but it is not a drug that has any good scientific basis to be used in COVID at this point. One thing that's important is that, the scientific process is messy. It's about ideas competing. And somebody has an idea that, hey, maybe we could use this drug, and they do a study and maybe it shows a positive effect. But we would never change a treatment protocol based on one study. We would change a treatment protocol when 8 out of 10 studies show something. And so you saw that messy process play out with hydroxychloroquine, but at the end of the day, when the dust settled, it is not supported by the evidence as an effective treatment for COVID. And there are potential side effects with hydroxychloroquine, not the least of which is cardiac dysrhythmias. So no, hydroxychloroquine is not something that should be being used to treat COVID. And similarly, ivermectin is the latest one. Ivermectin is a anti-parasitic drug. It's worth noting that we're dealing with a virus, not a parasite. And it is used mostly in animals. There are some human indications, but it's mostly in animals. And it is designed to deal with parasites, little parasites that have little flagella tails on the end of their cell. And ivermectin works by paralyzing that tail so they can't move, and then you can kill them because they can't get away. So COVID doesn't have a tail. COVID is not a parasite like that. It's a virus, and there is no plausible biologic mechanism that I'm aware of that ivermectin should work against COVID. And it's probably worth, it's sort of silly, but it's probably worth putting this up because my jaw kind of dropped when I saw this from the FDA the other day. But this is what the FDA has to say about using ivermectin to treat COVID. Is that you are not a horse, you are not a cow. Seriously, y'all, stop it. I don't know about you guys, but I have never seen an official government communication from the FDA look anything like that. So that was pretty that was pretty impressive the other day. Got my attention. What's interesting though is that with that and with some of the information on ivermectin, we're actually seeing people writing prescriptions for it, which is mind-boggling. Dr. Cho, do you want to talk to that for a second?
So, Dr. Jameson, yes, it is mind-boggling. So, with my specialty with infectious disease, I have prescribed ivermectin, not for COVID. It is for parasites, and I remember the few times I've prescribed it for strongyloides. It can cause lung infection. It's a worm, essentially, and for a bad manifestation of scabies, what we call Norwegian scabies, which is an insect. Dr. Jameson did describe the mechanisms appropriately. I just don't see how that would translate into a virus, a parasite, or something that large, so much bigger than a bacteria, and a bacteria is much larger than a virus. So I don't see the reasoning. The other thing that gets to me is if it worked, I would love it to work. I would be prescribing. I have prescribed it for other things. So why would a physician, in my mind, if there was a good option and the data was there, we would be prescribing it. My professional society, the Infectious Disease Society of America, does advise against prescribing at this time. So it's disappointing that we have our colleagues out there prescribing it.
Yeah, I think one of the things that the FDA, and Ryan, you're right to mention this, is that people may be using veterinary formulations of this drug to treat themselves, which is, again, also quite dangerous. So please, if somebody tells you that you should treat your COVID infection with ivermectin, just say no. Don't do it. It's not the right thing to do. So hopefully that covers it. All right. So from there, let's pivot to some therapeutics that may help. So we talked about steroids already, and it's worth noting that we have taken away the prohibition against solumedrol from the condition yellow clinical treatment. So that happened a couple weeks ago, and if anybody missed it, please make sure you understand that we now know more about steroids with this thing, and it's okay to give solumedrol if you have a severe respiratory patient that you think is COVID. It's okay, frankly, either way, but it's not prohibited like it used to be. So in the hospital, for anybody that's requiring oxygen, we're generally doing Decadron, actually, but there are some protocols that use solumedrol as well. So if you've got a COPD or somebody else that you would normally give the steroids to, it's okay to go ahead and give it. I wouldn't give it empirically to the COVID person. We'll take care of that at the hospital. But if you would otherwise be giving the solumedrol for asthma or COPD or some other reason, it's okay to use it, even if the patient also has a COVID suspicion or confirmed. So steroids, and Dr. Cho talked about those in the hospital. And then I think the other big thing that we want to talk about is the antibody infusions. And so I've been getting a lot of questions about these recently. And so I asked Dr. Cho to kind of give us a rundown of the monoclonals and what they are and what their indications are, et cetera. And then after that, we're going to talk with Billy, who actually got them the other day and wanted to share his experience. So Dr. Cho, go ahead.
Sure. So you've probably seen this in the news a lot, and it's being pushed at a state level as well. And the monoclonal antibody therapy is a important tool in the toolbox. And basically what it's doing is providing antibodies to fight off infection. It's more effective if given early in the course, specifically 7 to 10 days from the onset of symptoms. And once that person is hospitalized for COVID, it's a little too late. And basically what they're doing, when you give somebody a vaccine, your body sees that antigen, that protein, and then actively generates these antibodies, what we call active immunity. What the monoclonal antibody therapy does is it provides passive synthetic antibodies, what we call passive immunity. It has shown really a lot of good benefits. Studies have shown a 70 to 75 decrease in the risk of hospitalizations for those that get it, especially if they're early enough. The technology in itself isn't too new. We do it for other infections. If you, for example, if you were bitten by a rabid animal, we would also give rabies immunoglobulins or antibodies as well, along with the vaccines. So it's not new technology. It's not a new concept. It's used on a number of different diseases. Right now, there are 3 available monoclonal antibody treatments out there. The 2 readily available in the U.S. is Lilly and Regeneron. And those are a combination of 2 monoclonal antibodies that's given to really fight off early infections with COVID. Essentially, with these 2, you can be given up for 12 years of age and older who've been diagnosed with COVID or who've recently been exposed to somebody with COVID, use it as a post-exposure prophylaxis. And if that individual falls into the high-risk category for developing severe illness and hospitalizations. Now, if you look at some of the conditions that meets this criteria, it's actually pretty broad, and a lot of adults fall into this category. And just to list just a few of those, it's older than the age of 65, being overweight, a body mass index of greater than 25, pregnancy, kidney disease, diabetes, heart disease, if you're immunosuppressed, and a number of other chronic conditions. So as you can imagine, with what we see in the clinics and what you see in the field, a lot of people would potentially benefit from these antibody therapy. It's generally administered either by 4 subcutaneous injections or an IV infusion. I think a lot of the sites have moved to a sub-Q formulation just so that for ease of administration. And the hospitals, and this is what sold me on it too, is that the hospitals have been asking for it. They've been pushing it in the ERs because they want to decrease hospitalizations on the back end. However, it also does take up the ER beds. There is a 1-hour wait time to look for any anaphylaxis reactions, similar to what we've done with the vaccines. And then from a state perspective, they have been creating these community monoclonal antibody sites. There's one in a lot of our surrounding counties, Hillsborough and Pasco, Manatee, I think has one. And for the Pinellas location, we just opened it. We opened it on Thursday. It's located at the Holy Trinity Greek Orthodox Church in Clearwater on Gulf to Bay. And we have partnered with a vendor, CDR again. And you can register at the patientportal.com, or they do also accept walk-ups. In terms of some of the side effects, generally mild and well tolerated, but includes fatigue, cold-like symptoms, injection site pain, and obviously anaphylaxis, like any infused medication, is something that we watch out for. But I'd certainly you want to keep this in mind, especially if you develop COVID, especially if you fall into the high-risk categories. This is a great option for people out there. So with that, I'll take any questions.
All right, thanks, Dr. Cho. So while you guys are typing any questions that you have, I'm going to put 2 links in the chat. So the first link is from HHS, and it is to a page that has lots of good links to information about the antibodies. There's other COVID information there as well. But if you want to read up on this, they have both provider and patient sections. So if you want to read the actual deal for the healthcare providers. You can find it there. You can also find the information sheets for patients there. So that's the first one. And then the second one I want to put in here is a link that you can find an infusion center near you. So Dr. Joe just mentioned where, one of them is, but you can find any number of them where you can get these antibodies. There's probably a couple dozen of them just, in the Tampa Bay area alone. So hopefully those two links are helpful to you in thinking about it. So just to try to sum it up again, the antibodies are good regardless of your vaccination status, whether you've been vaccinated or not, it doesn't matter. They are good for getting early on in your course of illness and preventing your illness from getting worse to the point where you need oxygen or hospitalization, et cetera. And they are actually also approved for use after post-exposure prophylaxis for a high-risk exposure. So both of those are technically indications for them. They are not approved for pre-exposure prophylaxis, so you can't just take them every 60 days to give yourself protection. But these are indications, and they're widely available, and I would encourage folks to learn about them. I know for myself, I go in and I spend 10 hours at a time in a room with 40 COVID patients, and I'm wearing my PPE, but I sure hope it's working. And I sure hope I don't slip up and move my mask or something. But if I do get sick, this will be my first stop, and it will be there to, I will get it within the first day or two of being symptomatic. And I will hope that it prevents progression of disease. And keeps me from needing oxygen or going in the hospital or anything like that. So I think that's the sort of the summary of the antibodies. It is worth noting that this is in addition to the vaccine, and Tony's actually typing this while I say it. So if you come into the ER and you have, for example, a tetanus exposure, and you have not had a tetanus vaccine, I give you a tetanus vaccine to induce immunity in your body, but that induced immunity will not get there in time, right? I can't give you a vaccine to something you already are exposed to. So in addition to the vaccine, I also give you tetanus immunoglobulin, which essentially means antibodies, to give you that temporary protection. So it is temporary protection. It is not a replacement for the vaccine. It is another tool in addition to the vaccine. And I think that's really important to note that this does not take away the need to get vaccinated. This is an additional tool over and above being vaccinated. So please don't think that your strategy should just be to get vaccinated, or I'm sorry, to just use the monoclonals when you get sick. You really want to get the vaccine and get that level of protection up front. So not a replacement for the vaccine, but used along with it to keep disease from progressing to become more severe. So get both is the real answer. There is, because when you give when you give the antibodies, you're sort of giving temporary immunity. You do have to delay an additional dose of the vaccine for a period of time because your immune system won't appropriately process it and generate the immune response that you're looking for if you already have the antibodies circulating around. Just know that as well. Okay, a couple more questions coming in. Let's see. Crystal asks, Crystal, I think you're talking about the antibodies, and yes, they are absolutely recommended in pregnancy. In fact, that was one of the risk factors for severe disease that they were initially approved for. So yes, in fact, one of the most common times that, say, tetanus immunoglobulin, which is again just like tetanus antibodies, one of the most common times that we use those in the ER is among pregnant people when we don't want to give them that vaccine at that point, or they can't get a booster, or whatever the other reason is. So yes, to antibodies during pregnancy, absolutely. Next is, does the vaccine reduce the window someone would be contagious? That's a great question, and that's something that's kind of evolving over time. So Derek, when we all initially got our shots way back in December and January, we said we had to keep our masks on for a while. And the reason we had to keep our masks on for a while is because we didn't know for sure if vaccinated people could asymptomatically carry and transmit the virus, right? So you could be contagious, either with no symptoms or with very mild symptoms. And after a period of time, we figured out that with the original variant, the chance of that was very small. Now, we do know now that that with the Delta variant, even vaccinated folks can asymptomatically or with very mild symptoms carry and transmit the disease, which is why you've seen a lot of us go back to masking, go back to trying to avoid sort of indoor dining, those types of scenarios, even though we're vaccinated. And that's discouraging and annoying. I get it for sure, but you know, that is the issue, is that you can still, as far as the timeline for transmission, it makes sense that it would be reduced because you'd be able to fight it off quicker, but I don't have hard data on that time window there for you, Derek. I'll take a look, but I'm not aware of hard data on that. Okay, we had a question about pediatric population, 12 and older is what they're approved for right now. Okay, explain or mention about the spike proteins. I've read some things about autopsies and they're finding spike proteins in multiple organs that are causing MODS, may not be the exact content. Okay, so Simon, write out MODS, what your specific concern is with that, and I'll try to start answering, but write out specifically what the concern is there. So the spike protein is a protein found on the surface of the virus particle, and it is a protein that is essentially the key that fits into the lock, and the lock is the ACE2 receptor on the cell in your body. So your own cell's ACE2 receptor, and the spike protein is the key that fits that receptor. So the spike protein basically, if you can block the spike protein with an antibody, then you can block the virus from being able to attach to your cell and get in. Now, spike proteins, when you get the vaccine, that's what the mRNA vaccines code for. So it just makes your body machinery make a couple copies of this for your immune system to recognize, so you recognize the next time you see it. But you know, you have ACE2 receptors in lots of different organs in the body. They're more concentrated in some organs than others, like the lungs, the heart to some extent as well. So if you are infected and you have an autopsy, you would expect to see virus around where you have ACE2 receptors, because that's the lock that the virus key is fitting into. So I'm not sure if that's what you're trying to get at there, Simon, or not. So try to clarify it if I didn't answer your question.
Dr. Jameson, I can chime in there as well.
Oh, please.
I've heard this argument a little bit too. It falls into the infertility and the mRNA vaccines attacking it.
Okay.
With the proteins, the concern was some of the proteins, and I've seen this in social media where the proteins are similar enough that that it would cause infertility, that on the ovaries, and I could be way off with what the person's asking, but there's proteins from the vaccine and on placental cells are not similar enough to be confused with the immune system. I think I've heard this before, that as a proposed mechanism for infertility, and I know it's out there, but anything with a vaccine shouldn't attack any body tissue. There's no evidence of that at this time.
Okay, great. Hopefully that answers this question, but if that hasn't answered your question, ask it another way, or send me an email and I'll try to answer it better. Okay, so next is EMT 811KA. Any modifications for hurricane shelters during evacuation? Yes, emergency management in the county have a set of protocols in place to try to keep the shelters safe. It's a combination of distancing and testing and cohorting, et cetera. And I'm not sure what you mean by SPNS. So can you tell us what you mean by that?
Special needs, same protocol.
Oh, the special needs shelters. That makes sense. I'm not good at the abbreviations today, apparently.
Yes, same
Yeah.
protocol. DOH does staff that. We have partners working on the testing aspect of it too. We'll provide the masks, and we did socially distance with the beds.
So there you go. Yes, special thank you. Special protocols are in place for that. All right. So the concern was that the spike proteins were causing cellular or organ injury. Yeah, no. Viral infection causes cellular or organ injury. The spike proteins themselves are not the mechanism for that, to the best of my knowledge. Dr. Joe, do you have anything on specific organ or cell toxicity from a spike protein other than it facilitates infection by the virus?
No, it would probably be multifactorial. It's probably not even just the spike protein; it's the viral proteins, and it's your body's response. The spectrum of disease for COVID-19, you can divide it in two ways: the viral phase and the inflammatory phase. And it's your body's inflammatory response to the virus that causes the end organ damage. That's why things like the Decadron, the steroids, have shown to help with the severe COVID, because that's where the severe COVID is caused by that inflammatory phase. And some of these other medications that are used, like tocilizumab, baricitinib, they really are focusing on pathways to decrease your body's inflammatory pathways to further decrease and mitigate the damages to your organs. I hope that answered your question.
Yeah, and you know what? I want to tie on to that, because the way you said that reminded me of an analogy I wanted to share, and that's this: is that when you get an infection with COVID, for a large number of people, it may not be that severe, right? It might just be a bad flu kind of a type of a picture. It might just be, a week or two of feeling not good and struggling and all that kind of stuff. But clearly not everybody that gets COVID gets severe disease and hospitalized. We know this. But what's really interesting about it is what you were getting at there, Dr. Cho, with the inflammatory or the immune mediated response to it. I think it brings up a good analogy of the difference between an allergic reaction and anaphylaxis. And so lots of us get a little redness or swelling or whatever around a bee sting, and we don't like it, and it's not great. But very much fewer of us get a full-on, out of control anaphylactic response. And it's all the same mechanisms that do both of those things, right? It's a histamine release, it's all those other bradykinins and all those kinds of things that release. And if they're just a local little reaction, it's not that big a deal, and it's actually helpful. It's trying to get you to heal, which is like your body spiking a fever to try to kill the virus. But when it goes to something that's systemic and overwhelming, like an anaphylactic reaction, that's completely a different deal. And that's kind of what we're seeing, where a good number of people, they get sick, but it's not overwhelmingly sick. And then there's this subset of people that we haven't fully figured out yet, who get these crazy overblown immune responses, this inflammatory stuff that's equivalent to the difference between an anaphylactic reaction and a local allergic reaction. And I don't think we fully understand who goes into which category yet, but it almost is that same type of thing. One, you have a normal reaction to a respiratory infection, and the other one, you just get this crazy overblown, almost anaphylactic reaction where your lungs turn to mush, and then it's very, very, very bad. So I don't know if that helps people understand why some people get really severe disease and some people don't, and we don't fully understand it. It's like, we don't know why some people are allergic and get anaphylaxis to a bee sting while the rest of us are just allergic to it. So, or we don't know that until they get it anyway. So I don't know if that's a good analogy or not, but I did want to try to make that parallel. So thanks for bringing that up, Dr. Cho. Okay, so all right, at least Trevor thinks that was helpful. Thanks, Trevor. Appreciate you, man. So all right, so okay, yeah. So Ryan, there's nothing sharp that can cut you on a spike protein. It's just called spike because it's a spike that sticks out from the round virus. So thank you for that. All right. So the next thing I wanted to go to, and keep the questions coming. We'll try to answer them as well as we can. The next thing I wanted to go to was to Billy, and Billy was kind enough to agree to come on and kind of share where he's been over the last week, because I think it's an interesting story that we could learn from. So Billy, do you mind just kind of taking us through how the last week or two for you has been?
Yeah. So some of you guys may have noticed I've been out of the system for a few days, which is heartbreaking to most of you. But I did receive my vaccine. Let's see, I'm looking at my card right now. I got my first vaccine on 12/21 of 20. My second dose on 1/11 of 21. After the vaccine, I worked multiple vaccine sites, COVID transport team, always been active within the county, as many of you know. Friday, I felt like I was having a sinus cold. I was supposed to teach at EMS Academy. I went ahead and let them know that I wasn't coming in. I wasn't feeling well, but I wasn't sure. I thought it was just sinus cold I normally get. Sunday afternoon, I lost all sense of smell. So I was like, nope, I think I got it. I'm one of those breakthrough cases. Picked up an at-home test, took an at-home test, it showed up positive. So everybody in the house, we started staying away from each other because that's what we do. Monday, I woke up feeling terrible, weak, out of breath. It is not due to my size. I'm very physically fit. And then I finally reached out to Doc and said, hey, what else can I do? Give her some options. And he said, look up the monoclonal antibodies. So I started researching that, and I found a site right up by my house. I went up Tuesday morning at 9 o'clock, got the 4 sub-Q injections. By 12 o'clock, my smell came back. I had energy throughout the day. In the last 2 days, been waking up great. A little bit of a cough still, but my energy's there. I'm breathing fine. I spend a lot of time outside just because the sun seems to make it feel better. And then that's it. Sent another gentleman I know from our department. He went up there. He got the antibodies, and he has not had a cough. He's had regular bowel movements that he's been dealing with. So he was amazed at how fast it worked. So I guess my point is, one, I know that there's this big debate, and I do like to start a good debate, but if you guys don't have the vaccine, get the vaccine. We've passed too much time now. Get the vaccine. If you guys get sick, go get one of these antibodies. I promise you, that saved me a lot of heartache. Probably saved my marriage, because if I was down sick in this house, my wife, oh buddy, you guys that know her know. So get it done. You guys stay safe. It can happen. It can happen to any of us. Okay. But the antibodies, I highly recommend. I know I'm sending everybody there now. So if you guys do get it, go. CDR that we use at the vaccine sites, that portal is at patientportalsl.com. It'll give you all the information on it. You can make an appointment. I walked in. I had an appointment, but I walked in, and they took me right away. It was fantastic. You guys got to do this. No reason to sit home and be sick. There's options out there.
Awesome, Billy. First of all, apologies to your wife. That wasn't very nice. But I'm so glad you're feeling better. You know, you called me or texted me, I guess, at first. And it sounded like you were feeling pretty crappy, and you were kind of looking for options and what else to do. And I'm just really, really happy that you were able to get that so quickly, and that it turned you around so quick. And I'm not going to sit here and say that everybody is going to have that amazing turnaround that you had, but the data surely points us to that this can be a very helpful tool in making your illness shorter, easier, allowing you to get back to your family and get back to work quicker, and preventing you from progressing to the hospital or needing oxygen or anything like that. So I think we really do have a good option there. I agree with you. It does not replace vaccination, but it is definitely a good option. And I would encourage, as I said, if I become symptomatic, that will be my first stop. And I would encourage everybody else to consider the same, regardless of whether you've been vaccinated or not. I don't want to take the chance that I'm going to get that overwhelming inflammatory response and end up one of the folks that really struggles. I want to also just briefly mention that the age of the folks we're seeing is much younger than before. And I did a consult with a crew on Monday that had a 42-year-old that they were coding with COVID. And this is not I don't think a particularly ill or infirmed person. Our average age in the hospital this week is between is really in the 50s. In the ICU right now, it's between 55 and 60 for the average, and in the non-ICU, at least in my hospital, it's late 50s. So this is not this is no longer just an issue for older people. I think we're clearly seeing that, and I wanted to come on today and just update everybody as to where we are and what we're seeing and what the options are now, and really encourage you, if you have not already gotten your vaccine, now's the time to reconsider. It's been fully approved, it's available, it's easy to get any day you want it. And if you do become ill, please consider taking the approved treatments, which include the antibody treatment. And please stay away from the non-approved things. Don't do that. If I had $1 for every person I admitted to the hospital who told me that they're pretty young and healthy and they figured their immune system was good and got them covered, and yet there I am admitting them to the hospital on heated high flow oxygen. If I had a dollar for every person that I've found in that situation over the last couple of weeks, I could take a really nice vacation. So don't put yourself in that unnecessary risk, and take advantage of the tools we have now. They're here, they're available, again, please take advantage. And if anybody has any last questions, please go ahead and put them in the chat. Otherwise, I think you all have my email or a way of getting in touch. Please send any further questions in. Do not hesitate to reach out. We will do our very best to answer you. I don't care if it's a specific question about your situation or a general question or whatever. We will do everything we can to support you guys in your decision making and keeping yourselves safe.
Hey, Doc, can I take a minute? I got a story I'd like to share.
Please.
Yeah, so I did want to take a minute and remember Justin Burleth. He was a 29-year-old, just finished paramedic school, firefighter paramedic. He was with Nature Coast and with Inverness Fire part-time. And he died of COVID, and his mom also died. And he left behind a wife and a 5-year-old daughter. And I don't know his vaccination status, but the connection is that my son works Inverness Fire part-time, and rode with him, knew him. They even look alike. They're even 30-year-olds. So as a dad and a grandfather over this last year and a half, I try not to get into my kids' business. And I haven't said much about vaccination. But I called him up as soon as I saw Justin Burleth passing and said, to both of my sons, can you please get vaccinated? And within a few days of that, of course, they're like, oh, Dad, whatever. And my son became COVID positive, my daughter-in-law, and both of my grandkids. And my granddaughter is immunocompromised. luckily, both of the adults, my son and daughter-in-law, went and got monoclonal treatment. Worked incredibly well, but we're really, kind of rolling the dice on whether or not the grandkids would get very, very sick. And they dodged a bullet, honestly. That could have been a very bad pathway and affected, my granddaughter or grandson, or they could have gotten critically ill. And it just seems like a very high risk that, why wouldn't you want to be preventative instead of reactive? Both of these are new, medications that are out, whether it's monoclonal treatment or, vaccine. But I think from my standpoint, I want to be on the preventative side. So I just wanted to share that, that it was pretty concerning for our family. And we want to just remember Justin Burleth and his family.
Thanks, Craig. I appreciate that. It's worth mentioning that we've had others as well. You probably saw a young, I believe it was a Polk County deputy recently passed. We had a recent retiree who, by all accounts, was in excellent health from one of our agencies in the system pass. And so this is not theoretical. This is a very real thing. And I really hope that everybody will consider, we all every day do things based on science and medical best practices. That's how we treat our patients. That's our obligation. And I just, if you get sick with COVID and you go to the hospital and believe that much in modern medicine to go to the hospital to get taken care of, how do you not believe enough in it to follow the recommendations? The thing that has been just the most upsetting to me of this entire thing is seeing, frankly, preventable deaths in this spike. They are preventable at this point. This is a preventable disease. It is a vaccine preventable disease. And there's just really no reason why anybody should not avail themselves of that protection at this point. So I see one last question went up, which is, can you confirm whether or not the system is busy due to COVID or staffing issues? And the answer is both. Both of those things are contributing. While our staffing is an issue, and that's not just us, that's the hospitals, that's almost every industry or sector of the economy right now. Certainly it's particularly pronounced in healthcare, where people have been working their butts off for the last year and a half. But we also, as of a few days ago, somewhere between a quarter and a third of every patient in the hospital in the state of Florida was there with COVID. And we all know how much more difficult it is, how much more resource it takes, how much longer, the PPE, how it slows down every last thing you have to do to care for somebody, to have to do it with isolation precautions. So it's both, really. It's really both. So how is the system trending currently? So I think we covered this in the beginning, but we are optimistic that we are beginning to see the peak in cases for this wave. But we do not necessarily have enough data to say that for sure yet. We're hoping. We believe that the hospitalizations and deaths will follow and hopefully also peak within the next few weeks before they start to trend down again. But again, if any of us had a crystal ball on this, we would have been done a heck of a long time ago. So, all right, any last questions? Jasmine, any final thoughts?
I held them in the whole time.
Good job.
So if anybody has any questions, throw them in the chat. I do want to say, I know a lot of vaccine hesitancy has been based on fears because there's been a lot of things put out there, and your ability to answer questions for people has been very, very helpful. So you have made yourself available when people have questions, and I know that has helped people feel more comfortable with the vaccine. So thank you for that.
Did you talk about, sorry to interrupt, did you talk about pregnancy? I'm not sure if I missed.
It came up briefly. That is something that we have had some emails that have circulated about, and I've heard a lot about. I know that we do have some pregnant women in our fire departments right now that had some concerns, and I think a lot of those questions have been answered. But if you want to answer anything about fertility and pregnancy here, I think that comes up pretty regularly.
Sure. I'll just say it again. Both the American College of Obstetrics and Gynecology and the American Society of Reproductive Medicine both strongly advocate vaccines, whether you are thinking of becoming pregnant, currently pregnant, or recently pregnant. The risks of an infection with COVID are particularly pronounced in a pregnant person, and the risk benefit for vaccine is clearly in the benefit favor. And so both of those professional organizations strongly support vaccination.
I can say in our community, we have had some people who have been pregnant and COVID positive, and they've been concerned about all the medications they have had to take because they're ill. And we're thinking they should have gotten vaccinated. So something to think about. Obviously, if you're sick, you have to take medications that you may not want to be taking while you're pregnant. So I know that comes up regularly.
Yeah, thank you. Billy, any last comments? And thank you very much for sharing your story today.
No, I appreciate you letting me on here to do that. If I can get a few people to willingly to take the antibodies, that's great. I'm ready to get back to do some more med consults with you. I know you enjoy those so much.
Oh, Billy. Yes, of course.
I think this is great that we have this here now. You were lucky that you got them before everybody even in Pinellas can get them. So thank you for telling your story. Thank you for being here, Craig, Dr. Joe, Doc Jay. And if you guys find a need for us to do any more of these, obviously just shoot us an email, any of us, and reach out, and we can be here to answer questions or do another live stream if there's anything circulating out there that you guys need answers to.
All right, sounds good. So I don't see anything else coming in the chat. Jasmine, thank you very much for facilitating. Special thanks to Dr. Cho for taking time out of his day, and for Craig as well for joining us, and for Billy to share his experience with us. And please stay safe. Thank you for all the work you're doing out there, and do not hesitate to reach out if there's anything you need. Information-wise, resource-wise, etc. We'll do the very best we can to get it for you. So thanks, everybody. Stay safe.
Thanks, everybody.